usually clinical trials of analgesics use the outcome measure of visual analog scale for pain intensity, but you insist on using responder versus non-responder analysis. Can you tell me the better strength of your approach?
Yes. Well, this is the difference between measurement and outcome. Okay, what you do with the visual analog pain intensity score, you measure pain.
Right.
And what we've done in the past is to take the average change in pain scores from the beginning to the end of the trial. So, if on average it was 6 at the beginning and 5 at the end, we'd say there was an average 10 millimeter change on a 100 millimeter VAS. Okay, fine. Are you average?
I'm not sure.
Well, I promise you, you're not. Nobody is average.
Right.
And when it comes to pain relief, what you see typically is that people either get very good levels of pain relief or none. And so we argued that what we should be looking for is a level of pain relief that is likely to be useful to patients. So you've got to get to this level of pain relief to be what we would regard as a responder. And we set that as a 50% reduction in pain intensity. So if you started at 8, you have to be below 4. Now, for most people, that degree of benefit also means that you've also only got mild pain or even no pain at the end of the trial, which is fantastic for people. And if you ask patients, and we did a systematic review of studies asking patients, it's what they say they want.
Yeah.
The argument isn't about VAS and responder rates, because you use VAS to calculate responder rates. It's between average results and looking at it from the point of view of the individual patient. And the most important thing is that this business of 50% pain intensity reduction, or having no worse than mild pain, doesn't just give you good pain relief, it also means that sleep disturbances go away. Sleep comes back to normal. Fatigue disappears. Depression disappears. Quality of life rebounds. People are able to reconnect with their families. They're able to function, in terms of either their paid employment or looking after their families. This is a major change. This is life transforming. And if they don't get that, there's almost nobody at 49%. There's almost nobody at 48%. Most of them are down at less than 10% pain intensity improvement. So if they've got such low levels of pain relief, that's not helpful. But if you take the average, you get a result that nobody has. How can you? It's logically inconsistent.
But why do the other researchers keep on using VAS?
Well, most of them are not. It's true. That's because most trials are done for regulatory purposes, and regulatory authorities are way behind the cutting edge of this.
Right.
Think of a boat traveling across a lake, a still lake, and you see the bow wave. And the faster the bow wave goes, the sharper the wake. Well, we're going pretty fast. And these guys are in a very slow boat indeed. But we're working now with various groups within Cochrane, other groups, chronic pain groups, others, to establish these sorts of outcomes as the preferred outcomes from trials and systematic reviews.
Right. As an acupuncture researcher, I would like to ask you about the issue about acupuncture. There's no difference between acupuncture and sham acupuncture. Yes. If you see this figure, many acupuncture researchers say that the typical RCT design is not suitable for detecting acupuncture's efficacy.
Yeah.
Do you agree, or do you have any comment on this?
No, I think they may well be right. But that's not just acupuncture, okay? This is probably true about an awful lot of interventions. And let me explain why. When it comes to chronic pain, particularly is what we're really talking about here, the success rates, when we're talking here about achieving 50% pain relief, the success rates we have are at maximum about 30%. That means 30% people get pain relief, 70% do not. And that would be, for something like an NSAID in osteoarthritis or pregabalin in the diabetic neuropathy, something like that. When you drop that then to something like low back pain or fibromyalgia, your success rates are only 10%. And indeed, when you look at the standard clinical trial design, and you get success rate much below 10%, it's frankly impossible to tell it from placebo unless you have an enormous trial with many thousands of patients in it. We don't do that sort of trial. And indeed, it's because we're now looking at trials in this way that we've said we will, that we can see that actually it's going to be a jolly difficult state of affairs, particularly when you've got acupuncture, where you've got many things going on, and where you know that some people are going to do well, but you don't know who it's going to be. And it's very difficult to tell the difference between placebo. And we have the same thing for some drugs. I'll give you an example. We recently wrote a Cochrane review on I can't remember the name of the drug, but just a drug in neuropathic pain. And the conclusion was that we couldn't tell the difference between placebo and this drug. And one of my colleagues phoned me up and said, I know this is right. I've just had 2 patients in clinic who've had the most fantastic response on this drug that doesn't work. My attitude is you don't throw anything out the door, because your specialists will always want to try people on something when everything else has failed. There is a trial design that might help in some of these cases. It's called the Enriched Enrollment Randomized Withdrawal design, where everybody gets put onto a drug, and it's only those who respond by having good pain relief and able to keep taking the drug then go on, and then what you do is you randomize them to either carrying on with the drug at the level that's given them pain relief, or placebo. Now that's about 3 times more sensitive than the standard design. And it also tells you what proportion of people from a whole population are likely to get good pain relief. And I believe that if we were clever, we could adapt that design to acupuncture. So that's one way of doing it. There are other designs as well. One of them, for example, which is a modified version of that, would be a clinical effectiveness design. And we have published on this in the past. It's basically a modification of a randomized controlled trial, but one in which what you're trying to do is to see whether this is working in the real world. But the point is always that the outcome that you're measuring is people having good levels of pain relief and continuing to use the medicine. And it's things like that, minor things like that, which make the difference. So if it were me, and I were an acupuncturist, and I wanted to prove that acupuncture would work, I would be... No,
I don't want to prove that acupuncture works, but I want
to I do.
Test
acupuncture. In a funny sort of way, I do, because if one can prove that... How can you say this? There is what we know and what we believe. What we've got to do is to be careful about making sure that these two things are kept apart. Okay, I could tell you I know that there is no evidence that acupuncture works, but I believe.
But there are some.
I, as it happens, do not think so. But we will not argue about that right now. It's very weak evidence at best.
Yes, right, very weak.
Anyway, the point is this: that I think that there are other ways of doing it. I actually think that there will be a small proportion of people for whom acupuncture is of great benefit, and being able to demonstrate it would be really good, because if we could do it for acupuncture, then we could do it for a lot of other treatments that will benefit maybe no more than 5% of people. But for chronic pain, nothing works in more than a small proportion, and the benefits that we're talking about are life-changing benefits. So being able to demonstrate that there are these other therapies, you might not want them first line, but they're there in the background if you need them. Really important. Because I'll tell you, for chronic pain, there are never going to be any magic bullets, with the possible exception of stem cell therapy. And that's not going to be available anytime soon, and it's never going to be cheap, okay?
No.
Yeah.
Right. I would appreciate your valuable comments for the young researchers in this field.
Well, that's a very interesting question.
From your experience.
Yes, but that's my experience, and you have to remember I am me.
Yes, sure.
And from my experience, the most important thing to do is to keep asking awkward questions.
Keep
Asking awkward questions. I told you when I was a biochemist, I was told to go out on the wards, and of course you go onto a ward, and there's the professor of medicine talking about something. Oh, I know about it. You know, medicine's very big. I mean, it's huge. You know, in most westernized countries, you know, you're talking about something that consumes 10% of the GDP. It's enormous. We run it by having specialists who know an enormous amount about very little. But clinical biochemists like me have to know an awful lot about everything. And if you're going onto a ward and you wanted to talk to a professor of medicine, how are you going to deal with this? Well, I was told by a very old and wise biochemist. He said to me, Andrew, he says, just ask the question why 3 times. So, you know, so-and-so, somebody makes a statement, you say why. You get an answer, why. And by the time you get to the 3rd why, nobody knows. You're on a playing field of level ignorance, and then you can take it from there. You see what I mean? That's an awkward question. And then the other thing, of course, is that, again, this is me. I spent too long when I was young thinking that I was stupid because I didn't. True, of course, because I didn't understand things. Now, there are 2 reasons for not understanding things. One is because you do not truly understand them. You do not have the mental function for it. And the other one is because what you're being told is wrong. All right? And you come to meetings like this one here in Buenos Aires, and you go into the halls, and I'll promise you an awful lot of what you're hearing is wrong. And somebody said once that it was the editor of the BMJ, I think, writing an article, something like 98% of papers in the medical science literature were wrong. And other people have said this as well. There's a guy called Johnny Anides who writes these days, and he wrote a paper, and I hate him for it because it's one I would have loved to have written. He said why most medical research is false.
False. Yes, I read it.
You did. Well, it's a brilliant paper. It's lovely. And what can you say? I mean, most of it is. You know, studies which are too small, which use the wrong designs. And I use some of these in my lecturing, where you will see in a paper, you read the abstract, and the conclusion, it says, this drug is the best thing since sliced bread. I don't know whether you have sliced bread in Cambodia, but one of your everyday staples, you know, and then you think, oh, that's interesting. I'd be a bit surprised by that. And then you read the paper, and actually, if you read the paper, they present the data in the paper which demonstrates that their conclusion is wrong. And yet, these papers get published in reputable journals. So, young people, you can go with the flow and you'll probably do very well, and life's going to be boring. Ask awkward questions, ask why, and just assume that 98% of what we're being told is wrong. You won't go far wrong.
Very good advice for researchers, young researchers.
I doubt that
like
it's
me.
good. I doubt that it's good advice at all, actually.
It's very good. Okay, thank you very much.
It's been a pleasure, and I hope one day I get an opportunity to visit Korea. It'd be lovely.
Yeah, sure.
Thank you.
Sure.
Thank you.
You should come.
Bye-bye.
Thank you very much.